Good afternoon, everyone. It is my great pleasure to welcome all of you this afternoon, late afternoon for some of you. This webinar organized together by EWMA and ESVS, a joint webinar on venous leg ulcers with coexisting peripheral arterial disease. And it is even more my great pleasure to co-share this with Kirsi Isoherranen from Finland. Kirsi, thank you. And all the speakers that will present cases and topics this afternoon. Paulo Ramos from Portugal, Katariina Noronen from Finland, and also Joachim Dissemond from Germany. So again, welcome all of you, and it is my great pleasure now to ask Kirsi to make the introductions to this joint webinar, and please interact with us, put questions. We will be glad to have your input on this.
Thank you, Armando, for your kind opening. Indeed, my name is Kirsi Isoherranen, and I'm the current president of European Wound Management Association and the head physician of Helsinki Wound Healing Center. And it is my great pleasure to co-chair this webinar on this extremely important topic with Armando Mansilha. And we in EWMA are extremely grateful also with the great collaboration we have had with ESVS since last year. We started these joint webinars, and we have also have collaboration within EWMA conferences, and within wound care no one can operate alone. So it is very important that we network and we collaborate, work together, and that is why this webinar is also planned to be interprofessional, so that we have different perspectives on this important topic. And it is my great pleasure to introduce the first speaker, Professor Joachim Dissemond from Essen. He is a well-known esteemed dermatologist across the world, and he has been publishing very interesting articles on this topic recently as well. So we look very much forward to hear your presentation about the dermatological perspective on venous leg ulcers with coexisting PAD. So please, the stage is yours, Joachim.
Thank you, Kirsi. Thank you, Armando, for this kind invitation. And I would like to give you my lecture on hope. Now, can you see my screen? So the dermatologic perspective on the topic. And the topic is, as you already heard, venous leg ulcers with coexisting peripheral artery disease. And now the dermatologic indications are clear for us. It's venous insufficiency. And that's not dermatologic only, as those patients are treated in different disciplines. So leg ulcers, especially venous leg ulcers, venous insufficiency, is surely one of the most and best known indications for compression therapy. And the second one is lymphedema. I think that's more or less clear to everybody. What is not clear for everybody outside the field of dermatology is that we also do compression therapy on the lower leg if we have inflammatory diseases, inflammatory wounds, even inflammatory diseases without wounds. That means, for example, vasculitis or levedovasculopathies or other vasculopathies, necrobiosis lipoidica. If you have never heard of that, that's not a problem. Pyoderma gangrenosum. But what is important to us is if we have patients with lower leg ulcers, in most cases, we use compression therapy, especially if we see edema, because edema is a big problem in wound healing. So compression therapy against edema is extremely important to support our treatment. So a lot of indications, and we find more and more indications for compression therapy every year. And what are contraindications? And now I would like to present you the German guideline. I'm sorry, it's a German, but the German is also available in English since a few weeks. It's brand new. It's brand new, and it's PubMed listed. The German Society of Phlebology published that, the German guideline, and S2K guideline, and we find only 3 contraindications. That was different in the past years, because we had a lot of that, a lot of strict and relative. We don't have the term relative, because relative means at the end you do nothing, and that's not correct. We have contraindications, and 3 are left in Germany 2024. Phlegmasia ceruleara dolens. I've never seen that in my life. That means complete closure of the venous system. It's really an emergency, what you maybe see once in your lifetime, because that's really a heart disease. The second one is the heart failure. And look a little bit more closer, decompensated heart failure. That means not a well-treated heart failure is not a contraindication, only if it's decompensated. But that's not the topic of this lecture. The topic is the peripheral artery disease. This is a contraindication, but again, have a closer look on that. Advanced peripheral artery disease. That means critical ischemia. Having a closer look to that on the next slide, advanced PAD. What does it mean for the German guideline? They say if one of the following parameters is met, and the most important one is the first one, if the ABI is beneath 0.5. And that means, the perspective of a dermatologist, most of my patients has an ABI, maybe they have a pathologic ABI, but it's 0.7, 0.8. And that is not a contraindication. If you're more expert, you can do a closer look to arterial blood pressure on the ankle. And if the absolute pressure is beneath 60 millimeters mercury, that's also contraindication. If the toe pressure is beneath 30 millimeters mercury, it's a contraindication. And if the TCPO2 is beneath 30 millimeters mercury at the dorsum of the foot. But again, if you're not the greatest expert in this field, please remember ABI beneath 0.5. Yes, that's a contraindication. But if you treat a lot of patients with 0.987 or whatever, that is not a contraindication against compression therapy. Why do they, or we, because I'm the senior author of this guideline, why do we wrote that? Because we have a game changer study, and that was published by our great colleague, Professor Giovanni Mosti from Italy, with his best buddy, Professor Pac, Hugo Pac, who has done this study with 25 patients with so-called mixed leg ulcers. What have they done? First, they described what is a mixed leg ulcer, because we come back to this topic later on. I think you think in different directions, and they did a definition for them to say, okay, if the ABI is above 0.5 and the absolute pressure is above 60 millimeters mercury, then they did compression therapy with 20 millimeters mercury, 30, 40, and 50. And what did they see? They see that all measured parameters become better up to 40 millimeters mercury. That means if you do a compression therapy in a patient with an ABI which is higher than 0.5, every parameter becomes better, even if they have a more or less moderate peripheral arterial disease with compression therapy of up to 40 millimeters mercury. That was really a game changer in 2012. It is not new, but this is the first study who demonstrated that that knowledge that we all know, a lot of us know, on a scientific base. The same group did a little modification here and included diabetes. It's not the focus of our lecture today, but even diabetes is not a contraindication. It is a risk because if you have a polyneuropathy, you don't feel if you have problems, but it's not a contraindication. What they did is, again, 71 patients with diabetes and mixed leg ulcers and 109 patients with diabetes and venous leg ulcers. So the MLU means mixed leg ulcers. They had, again, compression therapy here with up to 40 millimeters mercury. And at the end, it was a safety study. They were able to demonstrate that they have no problems with the safety, even if the patient has an arterial disease and diabetes. And that has practical results for our times, because we have now stockings which are allowed in special, especially in patients with, here it is mentioned, early stage PAD. So remember, it is not a therapy for early stage PAD. It's a therapy for venous insufficiency. But if you have the comorbidity of a PAD, it is not contraindicated. And that's fine, because the stocking declares that. It is a claim, and that makes it easier to give it to the patients, because patients, or even some of the specialists, think, oh, it's maybe a contraindication. Here we have a stocking which is licensed for that. I myself don't believe that you need special stockings, but it is good if you have a claim who's declaring that's okay. And here of another company, you have the PAD and diabetes. So they declare, of course, it is not a contraindication if it's not a severe, not an advanced PAD, if it's not critical ischemia. That makes it easier to prescribe that and give that to your patients. So coming back, I'm from Germany, and I'm sorry for that, because this is a German publication. You only see the PubMed listed English abstract on that. And what have we done? We have done with our society, with the ICW, and a recommendation. And this recommendation is based on literature review. And then we have this interdisciplinary and interprofessional assessment of experts to find a consensus, because we were very unhappy with the term mixed leg ulcers. As you all know, think yourself, what is for you a mixed leg ulcer? And a lot of patients, because I'm a dermatologist, have a venous leg ulcer and the comorbidity, a little bit of arterial disease. So in early stage PAD means, in our view, that's not a mixed leg ulcer. This is a venous leg ulcer with a little bit of PAD, with a little bit of diabetes, with a little bit of whatever. But it is centrally a venous leg ulcer, and should not be called mixed leg ulcer, because in the head of a lot of people, they mean then compression therapy is forbidden. We suggested to call them arteriovenous leg ulcer if you have a severe venous insufficiency and a severe arterial problem. Then, of course, this is a mixed leg ulcers, and you may call that arteriovenous leg ulcer. That make a difference at the end. I will show you for the results of the therapy. And that's a third group. We have some patients with arterial leg ulcers with a little bit of chronic venous insufficiency, but chronic venous insufficiency doesn't play a big role here. Here you have a severe arterial leg ulcer. And the question is, if you have all these three groups, and my biggest group as a dermatologist is the first one with the venous leg ulcer, the question is, compression therapy allowed, yes or no? And that's clear. For the first, it's completely clear. Yes, yes, yes. You have to do compression therapy, because it is a level 1A evidence. You need compression therapy for venous leg ulcers. In the middle, for the second one, it is not so clear. In our cases, most of the patients receive compression therapy, even in severe PAD, but then the situation is not so clear. You have to look about the absolute pressure. If it's around 60 millimeters, you can do that, especially if you choose lower pressure. So, for example, 20 millimeters mercury is in mostly patients okay, but that's not yes or no. You have a closer look on the patient. And the third case is completely clear. It's a no. Severe PAD is a contraindication. Don't understand me wrong. Yes, PAD can be a contraindication, but only advanced PAD is a contraindication. Critical ischemia is a contraindication, and you don't have indication for compression therapy in this third case. Coming to my conclusion is, there are more and more indications and fewer contraindications for compression therapy. You can do a lot of good things for patients, bringing them to compression therapy. The diagnosis of mixed leg ulcers makes me a little bit unhappy, and it means that you have chronic venous insufficiency and you have a peripheral artery disease, but you should consider and adapt according to the severity of the two diseases. So have a closer look to that and try to find your individual aspect in each patient. PAD is not a contraindication to compression therapy per se, but it is contraindication. I think I said that around 10 times in this presentation. If you have critical ischemia, if you have your ABI beneath 0.5, yes, it is a contraindication. But if you have other patients like me, in most of my patients with early stage PAD, it is not contraindication. At the end, plan an individualized therapy option. Together with the patient, shared decision making is the term that you have in mind. And if necessary, start with lower pressure. And that's reality. So if we are not sure if the patient accepts that, if you will have pain from that, then we start with so-called light system. If you take bandages, it's around 20 millimeters mercury. Or if we choose stocking, artery, you can start with the compression class 1, which is in most, in every country it's a little bit different. In Germany, it's 18 to 21 millimeters mercury and a closer monitoring. And then I would like only thank you for your kind attention.
Thank you, Joachim. Excellent as always and very clear. And we have some questions in the Q&A. That's great. And everyone else can also write some questions, but there are already 2 questions. First, regarding the value of ABI in diabetic, is it worth to consider toe pressure rather than ABI?
Yes, if you have a medial sclerosis, of course, if you're able to do that, that's fine. The problem in the reality is that most of the centers cannot do that. So if you're able to measure it, especially in patients with diabetes, yes, that's fine, and that's the right way.
And then another question, what is the objective cutoff between this patient with mixed ulcer suitable for compression or not? I guess you showed it in one of your...
0.5. So if you look for the ABI, I think it's the easiest way to have a look on the patient. So if you have your ABI beneath 0.5, maybe the arterial problem is the biggest one, and then send them to an expert center to have a closer look what is really necessary for the PAD. So leaving that in mind is, I think, not only the German view, it's an international accepted cutoff. Beneath that, you have an arterial problem, a really severe arterial problem, and that should be solved by the colleagues, not by the dermatologists. We solve other problems.
Yeah, thanks. And then another question, will edema via longitudinal compression be sufficient?
I'm sorry, what?
Will edema via longitudinal compression? I think it means like this kind of under class 1 compression.
Under class 1 is difficult. We have a good data for class 1, even for recurrence of venous leg ulcers. Class 1 is much better than nothing. And class 1 is not thrombosis prophylaxis, is edema therapy. And we learned that from Hugo Parch, that around about 20 millimeters mercury is good. At the end, every compression therapy, which is well done, is better than nothing. And you see that on your own socks. So after the webinar, you see marks on your lower leg, and your socks has a compression therapy from around about 8 millimeters mercury. And that's enough for a little bit of edema reduction. But at the end, for recommendation, I think start with medical stockings, with medical products, and they start normally from class 1, 18 to 21, or with a light system if you take bandages, and that means around about 20 millimeters mercury. Beneath that, we don't have good data, and I think 20 is acceptable for really most of the patients.
Yes, thank you, Joachim. I warmly agree and very clear. And just a reminder that EWMA has currently published a compression therapy e-learning module, and there are some practical cases on this subject as well. Okay, thank you again, Joachim. And now it is my pleasure to invite Professor Armando Mansilha from Porto University, and he will give us the vascular surgeon perspective on this topic. So please, Armando.
Thank you so much, Kirsi. Let me share my screen. Can you see it right now?
We can see the first slide.
Okay, thank you so much. So now the vascular perspective on the topic that of course should be, and it will be, and normally in our daily practice must be complementary with the dermatological perspective that we just learned from Joachim. I don't have any potential conflict of interest in this presentation, and trying to introduce the problem and the rationale for being here today in this webinar. And according to the data that were published in the latest European Society for Vascular Surgery guidelines, we know that the venous leg also represents an important economic burden and on healthcare services for all of us in our NHSs. The prevalence of venous leg ulcer is around 1% of the population, rising to 3% for those higher than 80 years of age, and this is important to discuss because of the difficulty for elderly patients to use compression, not only because of comorbidities, but also because of other reasons. Up to 93% of venous leg ulcers will heal in 12 months, with 7% remaining unhealed after 5 years. Probably the majority of these because they are not pure venous leg ulcers and they have this peripheral arterial disease concomitantly that do not allow the healing of the ulcer with the venous measures that we usually apply. The recurrence rate within 3 months after wound closure is as high as 70%, not only for arterial reasons, but also for venous reasons and for wound reasons. And the point for today, in about 15 to 20% of venous leg ulcers, the patients also suffer from peripheral arterial disease of the affected leg with an ABI less than 0.5. And the point, of course, is how does it translate in clinical practice? Venous ulcers with arterial component. Not only that, how can we treat that? And if you go through the ESVS guidelines, we can read then in all patients with active venous leg ulceration, C6, it is absolutely crucial the prompt assessment and multidisciplinary management. That's why we are here today at this joint webinar, different societies, different disciplines, different health professionals taking care of these patients. Wound bed preparation and pain control is, of course, crucial for quality of life also of the patients. And close coordination between primary and secondary healthcare, again, as I just mentioned before, the multidisciplinary team approach for these patients. And now going through the different components of the treatment with different levels of evidence and strengths of recommendations. We have the object arterial assessment, 1C, treat the cause of venous hypertension that includes superficial venous incompetence and more with the recommendation to perform an early endovenous ablation with 1B level of evidence. Do not forget the possibility of iliac vein outflow obstruction and the possibility of being need to apply a venous stenting with class 2AB evidence. Compression therapy 1A, we will discuss that in deep, and of course, additional interventions that includes pharmacotherapy with venoactive drugs, antibiotics if is there any signs of evidence or not, debridement, and we can discuss this in deep after this presentation, after the presentation of the clinical cases. Number one, for all those patients, we don't have here in the recommendation, but I think I can add this word. For all patients with active leg ulceration, objective arterial assessment is recommended. Of course, many of them, the objective physical examination, it is enough when these patients have distal palpable pulses, and this can be enough. But for many of them, in particular elderly and diabetic patients, the continuous wave Doppler with the determination of ABI, and in some cases, we need also to assess the two pressure or to perform a duplex ultrasonography, and in particular, as I mentioned, in diabetes. And as I mentioned, it is mandatory, this arterial assessment with 1C level of evidence. For patients without arterial compromise that we need to treat the venous cause, I will not go in deep in this slide, but as you can see here, for healed or for active ulcers, the importance of compression and the importance of superficial early endovenous ablation, or the importance of venous stenting when you have deep venous causes as the problem for this venous leg ulcer. And concerning the compression, as Joachim just mentioned, in this 2022 ESVS guidelines, this recommendation that changed, and now with 1A level of evidence, we can read that for patients with active venous leg ulceration, multi-layer or inelastic bandages or adjustable compression garments exerting a target pressure of at least 40 millimeters at the ankle are recommended to improve ulcer healing. So with 1A level evidence, when we can, 40 millimeters, it is the minimum that we need to apply to these patients. But of course, we have contraindications. We just heard the German guidelines with the recent contraindications, and I saw, Joachim, that one of the authors of German guidelines is Professor Eberhard Rabe, and this table is from Professor Eberhard Rabe, and as you can read here, in the ESVS guidelines, we include not only those that you mentioned, but one or two more, as you can see here. Severe lower extremity atherosclerotic disease with ABI less than 0.6, not 0.5, but I would say that probably this is not the crucial point, and or ankle pressure less than 60. Another point important for us is when these patients have an extra anatomic or superficial internal arterial bypass at the site of the compression that is completely forbidden to apply compression on these patients. Heart failure, as Joachim mentioned. And of course, I will not go in detail about the confirmed allergy to compression material and how to solve this difficulty. And last but not least, we cannot forget those patients with severe diabetic neuropathy or with sensory loss or microangiopathy with the risk of skin necrosis. As Joachim mentioned, we can discuss if this is an absolute or relative contraindication or if it is not at all a contraindication right now, according to the recent guidelines that you just mentioned, if you have later evidence produced after these 2022 guidelines. This new recommendation with 3C, what is not too much as we know, for patients with venous leg ulceration with ankle pressure less than 60, toe pressure less than 30, or ABI less than 0.6, sustained compression therapy is not recommended. For patients with, and here you can find the term mixed ulcer caused by coexisting arterial and venous disease, modified compression therapy under close supervision with a compression pressure less than 40 may be considered, provided the ankle pressure is always higher than 60 to BC level of evidence. And for patients with healed venous leg ulceration, long-term compression therapy should be considered to reduce the risk of ulcer recurrence with 2AB evidence. So I would say that not take-home message, because we have a long webinar to discuss all these topics, but as a kickoff, I would say that these patients with venous leg ulcer are often elderly and the coexisting comorbidities are common. The presence of this lower extremity atherosclerosis disease, or PAD, is particularly relevant. So a basic assessment of arterial status, continuous wave Doppler to measure ankle pressure and ABI should be performed. In patients with diabetes and incompressible arteries, evaluation using arterial duplex ultrasound or two pressure may be required to exclude arterial disease or contraindication for compression, and modified compression may be beneficial in these patients with coexisting venous leg ulcers and peripheral arterial disease. Again, thanks for your attention. Happy to discuss. Thank you.
Thank you, Armando. Interesting and very clear. And yes, and now we have a lot of questions as well, and we won't be perhaps not able to answer all of them. We will try, but the first question to Dr. Mansilha: what should we do with patients with incompressible arteries or patients with marked arterial calcification? This is a question from David Perez Parreno.
Well, I probably I mentioned this, and also Joachim in his presentation. In these patients with incompressible arteries or marked arterial calcification, and in particular diabetic patients, sometimes or many times it is not enough to perform the continuous wave Doppler assessment, or and it is also many times impossible to determine the ABI, and we need to assess the two pressure or to perform arterial duplex ultrasound of the arteries.
Thank you. Then one question, what is your cutoff to trigger either revascularization or treating the venous cause? And what is your way to treat, synchronous or sequential?
Well, Kirsi, I would say that this is the holy grail. That is the point. We need to understand if these patients with coexisting venous leg ulcer and peripheral arterial disease if this arterial component is critical. If we are in face of a critical limb ischemia, usually those patients with less than 0.4, that's for sure that we need to perform any kind of revascularization if we can do it. In 0.4 and 0.8 disease in the middle, higher than 0.8 usually we don't need at all. And of course, as we mentioned, for compression therapy, 0.5 or 0.6 can be probably the cutoff. But when we have to consider these patients for previous revascularization, because it will be completely impossible to heal the leg ulcer because they don't have enough arterial component for that. When we have these patients, more and more, and in particular in these patients, we try to go through endovascular approach, because many times we are facing diabetic patients, and the problem is infrapopliteal, and that's why we try to perform these angioplasties of the leg arteries, even if we know, and in the future they will close again. But that is not the point. The point is if we can open by angioplasty, and if this is enough to heal the ulcer for the future. If it is enough, and then we don't have any kind of recurrence, and if the patient is not so much symptomatic, we don't have to perform nothing again except follow the patient. So that is the point. I'm not sure, Mohammed, if I answered to your question. I think.
Yeah, I think it was quite clear, and I suggest that we move on now. And if you gentlemen could write also on the Q&A and chat if you would like to clarify, but I will hand over to you, Armando, so you can present our next speaker.
Thank you, Kirsi. And now I would say that probably the majority of the participants will appreciate so much presentations of clinical cases, but because in fact it is what we are doing in our clinical practice. And we will start with Paulo Ramos from Portugal to present the first one. Please, Paulo, thank you for being today with us and to share your experience on this. Thank you.
Thank you, Armando, for this kind presentation, and thank you for getting me involved again with this close partnership between EWMA and the European Society of Vascular Surgery. So I will present a case about compression therapy in the case of a patient with peripheral arterial disease. My name is Paulo Ramos. I'm a clinical specialized nurse in wound care and tissue viability, and I work in a community care center here in the north of Portugal. So regarding this presentation, I don't have any kind of financial interest or disclosures to make, and just move forward to the case. It's an 88-year-old lady, and she had a past of thrombectomy of the popliteal artery on the left leg in 2014. As a medical background, is an hypertension patient with anemia, iron deficiency anemia. She had documented peripheral arterial disease on the left leg and dementia. A partial dependent patient on daily activities. For example, she walks with the help of a walker, and she needs some help in her daily activities. In October 2022, she had a small trauma at home in the furniture and start the treatment of that wound in consequence of the trauma in this family nurse and GP. And because the wound is get worse and worse, in 2022, she was referred for a vascular surgical consultation due to the past of peripheral arterial disease on the leg that was that suffered the trauma at home. After a vascular surgical consultation, she was proposed for a medical approach. She was prescribed Suloxane, 2015 milligrams, and she was after evaluation, it was said that she had enough perfusion for healing and no indication for surgical approach in terms of vascular surgery. She had a very painful ulcer, but she refused to take strong painkillers because she suffered some side effects of tramadol, and she was very reluctant to new medication, and even some antibiotics that she do in the past, she was very reluctant to do it. A fragile patient, so we have here a multi-comorbidity situation, and she was again very reluctant to compression. We try to use short stretch bandage. We try to use lit compression bandage, as Joachim already approached. These are some of our therapeutical weapons or systems that we have in our facilities to provide compression therapy, but was not possible because she did not tolerate. So this was the wound when the patient comes to me in the 27th of January of 2023, and 10 weeks after we did not achieve the improve that was expected. We have the tendon exposure, we have a better condition of the wound bed, but the wound is larger now. And between these 10 weeks, we try to apply compression therapy to reduce the edema, but without the effective way, in an effective way. So after all these attempts, we decide to try one of our other solutions that we have at the moment in the market, that are adjustable compression garments or adjustable compression wraps that could that allow us to dose the compression on the limb that we want to apply. So we can apply 0 to 20, 20 to 14, and more than 14 mils of mercury in the leg of the patient. And with this system, the patients start to tolerate the compression therapy. Another challenge on this case is how can we provide the right care to the ulcer. We need to cleanse gentle these wounds because it's a very painful wound. We must have dressings that do not provoke more trauma or induce more trauma to the wound bed. And for a primary dressing, you use hyaluronic acid with silver powder just to control the bioburden and to promote the healing, and is not toxic to the tendon. Even we know that this tendon will be almost autolytic debride because it is not viable at the moment. And again, we have some issues with the traumatic application of dress. Even with soft silicone dressing, sometimes it provokes some trauma, and you can see here in this area. So we continue, and we see now 4 weeks after we can we were able to apply the compression. The wound immediately improved. The wound bed is much more viable now. We have very healthy granulation tissue. We have less edema, less inflammation, but we are struggling now with some, for example, pressure points that sometimes can happen for the use of inadequate shoes, for example, for this dislocation of compression system that could sometimes, as you can see here in this picture, put some conflict areas and provoke some pressure points in the tibial area on or in the articulation of the foot. But you can see here now after 8 weeks we achieve a very viable wound bed with granulation tissue, viable tissue, epithelializing, the borders are epithelializing now, and so the edges of the wound are much more healthy, no inflammation, and of course a good control of exudate, less pain now, because compression could help me in control of pain too, because less inflammation, less pain. And we continue after we discover that the patient tolerates this compression therapy system. We continue to apply and then follow up the patient 15 weeks, 18 weeks, 2 times a week. The patient comes to the clinic. We perform a gentle cleansing, the application of the hyaluronic acid powder, and the soft silicone dressing and compression. After 21 weeks, we change the local treatment to a collagen dressing, and as collagen will adhere to the wound bed and you will promote the healing. And after this, since we don't have much more exudate, we can decrease the frequency of the treatment. So once per week, collagen dressing with soft silicone and compression with adjustable compression garments. And after 38 weeks, we achieve the completely healing of this ulcer. I think it's an interesting result because with such scenario of huge comorbidities, a fragile patient, a fragile skin, with a lot of barriers to go through, I think we achieve, and this ulcer at this moment is ill, and the patient is completely free of this problem. So this is the final result, always in an ambulatory setting. So this patient was never an inpatient or was admitted in the vascular surgery or other wards. It always treats an outpatient clinic. And as take-home message, I think compression therapy should always be considered in a management of leg ulcer with patients with peripheral artery disease. It seems for me, in my personal experience, we know that we have elastic systems, but the inelastic compression systems usually are much more well tolerated in the leg ulcer patient with peripheral artery disease. But this is only my personal perspective and my personal experience, because the patient didn't feel the squeeze effect of the elastic component of the system. And of course, the term of dose of compression. So we have different kind of patients with different barriers to the compression. We must adapt the systems that we have in the market to our patient, and sometimes we must dose the compression to better compliance or to better adherence of the patient to the compression that we suggest, or that is the more adequate to his or her condition. And of course, compression therapy is a huge therapeutical weapon because it reduces the edema, controls inflammation, improves the venous reflux and the artery inflow, because less edema, it's more space to the artery, deliver the blood to our lower limbs. So it helps in pain control because less inflammation, less pain, of course, and improves the quality of life. So this is my message. This is my experience. Of course, this is always debatable, the approach that I have here, but it was at the time the best available approach that we have with the resources that we have available. So of course, there is always other ways to do it, but I share with you one of what I consider a successful approach. Thank you so much once again for your attention, and of course I'm here for questions, remarks, and comments.
Thank you. Great case. And great results at the end. That is much more important. I'm not sure if we have specific questions for you. Kirsi, do you know if we have specific questions?
There is at least one. What do you think about the use of negative pressure wound therapy in this case?
It can be optional, of course. Negative pressure wound therapy has a huge effect for control of exudate, and sometimes we use compression therapy with negative pressure wound therapy. In this case, was not what we intend to do because of the initial level of pain of patient with a constant suction, it could be too much for this, and it was not considered, but it can be done, and it could be, or it is possible even in this case to do it. So
I have one comment or question. In this case, of course, we are discussing when fragile patients with a lot of comorbidities and reluctant for this and for that. But in these cases, sometimes, not in this particular case, but sometimes, and having in mind the angiosome model and theory, sometimes if we can open the inflow artery for this particular region, for example, in this case, the peroneal one, with an endo approach that is minimally invasive without, well, I would say, without great number of complications. Probably it would be faster, the healing of the ulcer, even having all this wound care that you mentioned, and it was outstanding. But my point is having in mind that sometimes a minimally invasive approach to open the inflow artery can be an important approach also for these patients. Just a comment, Paul, if you want.
Yeah, of course, but the patient was evaluated for a vascular consultancy, and at that time, with the condition of the patient, and I think evaluating the favor and the beneficial and the risk for the patient, and after they evaluate, they see that they have enough perfusion for the healing, they recommend not to go further for a vascular surgery intervention. And even that someone is asking here, what about the skin graft split? It could be possible, but again, 88 years old patient with a lot of comorbidities, a fragile patient. Sometimes we know that to be too much to do too much intervention in this kind of patients, sometimes the result is a complication and it's not beneficial. Sometimes it's more beneficial to wait a little more time and to and see the progress of the wound. And in the beginning, it was not easy for me to wait 10 weeks to see and to adapt the patient to the systems of compression. But I wait. I'm very patient, and after we always say we adapt the patient, or we adapt the system to the patient, all goes very, very, very well. About the tendon exposed, the tendon was debrided, autolytical debrided, because someone is asking, and in the end we cut the tips of the tendon and it was removed, and the other one was recovered by the granulation tissue, so, and never infected, fortunately. So of course, as I mentioned, it's always debatable the approach that I have, but is consider the beneficial to the patient and the risk for the patient. It was the best approach that we have to offer to this patient with the resources that we have.
Thank you, and it was a great result at the end. Thank you so much for sharing with us this huge positive clinical experience. And Kirsi, if you agree, probably can move forward to the next clinical case.
Yes, thank you. And Paulo, if you would like to answer written
Yes.
some of the questions. And now it's my pleasure to introduce you my dear colleague Katariina Noronen from Helsinki Wound Healing Center. She's a very experienced vascular surgeon and we are working very closely, and Katariina will present us a case from a vascular surgeon perspective. So please, Katariina.
Thank you for the introduction, and good afternoon or evening, everyone. I actually have two cases, so I'll dive straight into the first one. So the first patient is a 72-year-old female. She's a smoker, she has hypertension, she does not have diabetes, but she has in the history a laser ablation of both accessory anterior saphenous veins done and local phlebectomies. Last May, she came to our outpatient clinic with these small ulcers on the ankle, but now she had also developed a pretty severe claudication with only 10 meters and then getting pain in the calf. She has a walking aid and also some sort of wrist pain. On clinical examination, she was classified as C6. She had edema and no peripheral pulses could be found. So the ABI was 0.3 and toe pressure 29. So clearly ischemia is present. On bedside ultrasound, there was also venous insufficiency. The great saphenous vein was with a diameter heavily ranging from 6 to 12 millimeters and refluxing, and also superficial refluxing varicosities both on the thigh and calf. She underwent arterial imaging, which is MRA in our institution, and there was a stenosis in the common iliac artery, and then total SFA and proximal popliteal occlusion, and then below the knee there was only a short stump of distal popliteal open and occlusion in the anterior tibial artery. So the ideal revascularization would be endovascular treatment for the iliac stenosis and a vein bypass for this long occlusion. But like I said, the great saphenous vein was not usable, and neither was the one on the other leg. And looking at the late phase of this MRA, this describes the venous system on her both legs. And also we scanned the both arms for arm veins, but those were also not suitable. So what the plan was to go for the endovascular treatment because of the iliac stenosis, and that was done without problems. But the SFA recanalization was not successful at the same time. She stayed overnight, and the next day the rest pain seemed to be a bit better. So the plan was to take a little time out because the ulcers were fairly small, and then she was invited for a follow-up visit at 1 month. Then at 1 month, there was now a bit more of these superficial wounds, but the rest pain had come back and actually gotten worse. And the ABI and toe pressure were not any better. So clearly something has to be done. So a second attempt at endovascular treatment was assigned, now in general anesthesia in the operating room. And the treatment started with the puncture of the left common femoral artery and then coming crossover to the right side. But from upwards, again, the SFA recanalization was not successful. So what normally then is done is to look for an approach from the opposite direction. And normally the popliteal artery is the place for the puncture, distal puncture site. But in this case, the popliteal was occluded. So the best puncture site was on the dorsum of the foot, the ADP. And coming from ADP with a wire, the anterior tibial artery, popliteal, and SFA were all fairly easily recanalized, which led to a meeting of the wires on the right groin, except that these are not yet in the same lumen. So it required some more maneuvers. And some moments and devices later, the wires did met in the open lumen in the right common femoral, and then the wire that's coming from down is lassoed out from the left common femoral, resulting in this through and through wire, which then serves as a nice pathway for the endovascular treatment devices, which in this case were several balloons. These are not all used, but some of those, because it required the treatment of the whole SFA, the whole popliteal, and basically the whole anterior tibial artery as well. And after images of the ballooning, it was deemed that stenting of the SFA and popliteal was also required. This led to a lot of stents from the groin up down to the distal popliteal. And in these images with the contrast media, you can see a really nice open line from the groin all the way to the foot. And now the anterior tibial artery is also nicely open. So post-operatively, then on the ward, the wrist pain relieved fairly quickly. Unfortunately, ABIs and toe pressures couldn't be taken because of the sore ulcers, but clinically it was clear that the circulation is improved and the stents are open. So she went home with the medication of aspirin and rivaroxaban permanently and clopidogrel for 1 month. For the vein insufficiency that she still has, she is coming back for the laser ablation of the great saphenous vein. The superficial varicosities don't need treatment necessarily. Compression bandages and wound care is continuing at home, and the hope is that when she comes to the laser ablation, hopefully the wounds are nearly healed so that we don't have a risk of infection there. Okay, so the next one, this is a 64-year-old male, also a smoker. He has diabetes, can be considered sort of a fit person, lives independently, doesn't have a walking aid or anything. He has had a deep venous thrombosis on the left thigh 10 years ago, and at the same time was diagnosed with APC resistance. And since then, he's been on permanent apixaban medication. He has also had a left SFA stenting 5 years ago due to an ulcer on the foot. Now he came with an ulcer on the dorsum of the foot that had been there for 2 months and slowly gotten worse, and also developed rest pain in the foot. On clinical examination, the foot was cold, there was edema, and again, no pulses could be felt. So his ABIs were actually not that bad, 0.06, and toe pressure of 50, pretty low, the PVR curve, but the clinical look of his foot was clear that there's ischemia involved in this badly healing ulcer. On ultrasound, the great saphenous vein was deemed of good quality, which was 5 millimeters lying down, raising the suspicion of insufficiency as well. Deep veins were normal breathing variation, so no like post-thrombotic syndrome suspected. So on MRI, there was occlusion on the SFA. It was the stent area that had previously been put there 5 years ago, and this was checked also with ultrasound because on MRI it doesn't always show the stents. But in addition to that, he had a stenosis right at the knee joint, and actually this is not the distal popliteal, since the anterior tibial artery starts before this. This is an anatomical variant that it starts higher up than normally. So in this case, if there hadn't been the SFA stent, perhaps the endovascular treatment could be considered, but considering the stent, considering the stenosis and the knee joint and the good great saphenous vein, and also the hypercoagulation disorder he has, a bypass was chosen from SFA to the below the knee. And this way, basically, we're treating both insufficiency at the same time when we're taking out the insufficient vein and using it for bypass. And next, I'll show you a short video of the operation, which starts before the operation with the ultrasound of the vein. This is the horizontal view coming from calf up. There's a side branch coming in, and then on the thigh, you can see that the diameter stays pretty much the same, so this can be deemed good quality. And the operation starts always with the exposing of the anastomotic sites and then vein. And this is the vein. We take it out from separate incision, and here it is taken out and looks good. Then the proximal anastomosis. This is the SFA that is clamped on both sides, and the vein is then sutured into the opening with the matter of into side. And even though it really is an insufficient vein, it looks pretty good. And the final knots, and now when we open the clamps, you can see that it's filling up immediately, so there are really no valves stopping the flow. Except right at the distal end of the graft, there were a couple valves still functioning, so the blood wasn't coming out yet. So we used this valve cutter to cut the final valves from the vein. And then check the inflow. It shoots up nicely. And then after securing the side branching and a little fine tuning, we get a good graft, which is then tunneled anatomically to the below the knee, and then the distal anastomosis. And then at the end of each operation, we always measure the flow to secure that the graft is functioning well. And here is a nice curve, and 140, that's good, and revision of that wound then afterwards. And then after the operation, again, this patient's breast pain relieved immediately. The ABI improved. Toe pressure stayed pretty much the same, which we often see on first post-operative days, but the PVR curve now is totally different. And on ultrasound, the distal anastomosis was nicely open. And he went home with his permanent apixaban and then aspirin for 1 month. And also continuing with the compression bandages, because even though now we kind of cure the venous insufficiency, swelling might occur due to the improved arterial circulation. So he will be needing those and be used only to the point of the distal anastomosis site, because it's a fresh graft. Thank you.
Thank you, Katariina. Amazing. And I think it is very important to show that in this, in the latter case, that it's important to use compression as well. And I think here we have questions to you both, to both Armando and Katariina. There is one question at the Q&A section. Do you always treat great saphenous vein reflux with endovenous ablation, or do you ever treat with Shiva in cases with not dilated great saphenous vein in order to maintain its patency in case it could be used in the future for bypass in arterial revascularization? Would you like to start, Armando?
Yes, Kirsi, this is a great question. And Katariina just mentioned one important distinction that I would like her to even explain a little bit better. That is the difference between one insufficiency vein or one varicose vein. That is not the same thing. And this is important because, as Katariina just showed, we can have veins with reflex that can be used for this distal bypass, but varicose veins cannot be used, and this is the crucial difference. Katariina, can you explain this even better?
Yes, well, it's about the diameter of the vein, or that it stays consistent. If there's like varicosity is like 1 centimeter bumps, it's not going to be good. The flow will be then circulating, and I don't know. I haven't tried it with that one, but I'm guessing it's. But if you have, I think it could almost be the best possible conduit to have a little insufficient vein that it's slightly dilated, because then we also have problems with the too narrow veins.
Yes, of course. And having this in mind, what you just said and you showed, and trying to answer the question, yes, in many patients, and particularly when we have veins that have an increase in diameter but are not huge, for example, one great saphenous vein with 5 millimeters with reflux, in an elderly patient, diabetic, we try as much as we can to preserve this vein. And yes, sometimes we can perform these other techniques to treat superficial plaques if we believe that this vein can be important to be used in the future.
Thank you. And there are some other questions as well in the Q&A. If you could please, Katariina, answer them written so we can move forward. And it is my pleasure to...
I would say that it is my pleasure to present the next speaker because the next speaker is Kirsi.
Thank you. And I just want to be sure that you see my slide.
Not yet, Kirsi.
Okay, I will try again. Always some technical.
Yes, perfect right now. Thank you. Yes.
Yes.
Thank you.
So my case is a little bit different. This is like not the typical venous leg ulcer, but an ulcer with edema, type 2 diabetes, and peripheral arterial disease. But I think this is an important case to show because in clinical practice, we see more and more these kind of very hard to heal ulcers. These are my conflicts of interest, but they do not have any interference to this presentation. And first of all, the patient has given oral and written consent to present his case. He is a 50-year-old man, so quite young. And since December 23, he had an exudating ulcer in the right foot between the first and second toes. The BMI was 34, so he was a little bit obese, and he had been smoking since 35 years. He still works as a business consultant very actively. And when he went to his GP with the ulcer, diabetes was diagnosed at that stage, and the HbA1c was 70, so probably the diabetes had been there for at least 1 year. And he, because of that ulcer, he was referred to vascular surgery department. And here we can see his foot at the first visit. All the peripheral pulses were palpable. And in the duplex ultrasound, there was good flow in ATP and ADP and no signs of venous insufficiency. So he had not a venous leg ulcer as a pure, but he had leg edema at both legs due to obesity. The toe pressure was thought to be a little bit low because of pain and not reliable. And he was planned to have an MRI, but it was cancelled because he had quite severe back pain and he couldn't lie on his back for longer periods. He was given advice to quit smoking, compression therapy, and he was referred to plastic surgery department. And he visited the plastic surgical department on April. And he had got then some new medications, metformin, rosuvastatin, furosemide. His blood pressure still was quite high. The plastic surgery was a friend of mine, and then she called me and asked whether we should continue conservative treatment at the dermatological department, and I said yes. He had some neuropathy in the right foot, and at that point, short stretch garments were provided for the patient from the hospital in order to do the compression therapy regularly. Okay, then the situation, as you can see from the pictures, got worse. During the period he was waiting for our consultation at the dermatological department. Then he had got some new medication, ramipril and capabentine for pain medication. And when he came to us, we saw instantly that the short stretch garments were too loose, and there was a lot of exudation, no adequate dressings. And at that point, we switched again to inelastic bandaging, and we referred him to the nutritionist. And then we planned that if there is no response to this treatment, we will refer him again to the vascular surgical department for the MRA that was cancelled due to back pain. And we planned a control visit within 1 month. Well, the situation got obviously worse, and he was hospitalized at our dermatological ward in June. And there we have every Wednesdays a multidisciplinary round with a dermatologist, vascular and plastic surgeon, infectious disease specialist, nutritionist, physiotherapist, and podiatrist. He had an elevated factor 8, so the thrombotic profile was raised, and we started rivaroxaban and mini aspirin. And I still remember that we discussed together with Katariina, and Katariina said, okay, yes, we should do the MRA, because he was young, 50 years old, and with this kind of peripheral ulcer. And indeed, in the MRA, the arterial tibialis anterior was stenotic, and a percutaneous transluminous angioplasty was performed in June. Of course, there was also pseudomonas colonization. So as local treatment, we used cadexomer-iodine, boric acid, maggot therapy as well. We tried to apply the compression therapy very strongly with intermittent pneumatic compression together with inelastic bandages. We also referred the patient to endocrinology to optimize the diabetes treatment, but unfortunately they returned and said that the treatment should be continued at primary care. Also, to exclude atypical causes, we took a biopsy from the ulcer from the right foot, but there was a normal ulceration, no signs of atypical ulceration like Martorell, livedoid vasculopathy, etc. At that time, the patient was saying to me that, yes, indeed, he would like to act as a patient advocate. And I think this was really nice that he showed empathy to other patients as well, that I have spent 4,000 euros for wound dressings. As a business consultant, I could afford that. But what about all the patients with older age and low pensions? Well, the story continued. The patient's wound treatment took some 2 to 3 hours at primary care. There was excessive bleeding due to anticoagulant therapy. The patient visited emergency department very frequently, several consultations, and new hospitalizations in July, and unfortunately the patient is still hospitalized. An MRSA was found on the ulcer on July, and for instance, vancomycin and ceftazidime were used intravenously, and in the native X-ray, an osteomyelitis was also found on the second tone. And we had GPs had difficulties in controlling blood pressure. But here we can see a promising result of maggot therapy. So here we can see that the ulcer is very ready for skin grafting, but unfortunately the skin grafting was cancelled once due to sepsis. He got an Acinetobacter sepsis. And compression therapy continued all the time at hospital with intermittent pneumatic compression and inelastic bandages. But finally, skin grafting was performed on the beginning of October, and also right second toe amputation because of the osteomyelitis. But the patient developed acute respiratory distress syndrome during anesthesia, and he was treated at intensive care unit for 11 days. So quite dramatic. But luckily, the patient survived, and this is the situation yesterday at plastic surgical department. And I could not be more happy for the patient. What did we learn? Prevention for sure is always more effective than treatment. What if the diabetes had been diagnosed more early? He would have proper lifestyle modification advice early, like quitting smoking and compression therapy already some years before due to edema. And what if the patient had had an early access to diabetic foot group? But for sure, interprofessional collaboration is the only way for successful outcomes in these complicated cases. And we have good referral pathways written, but they should work in practice. And here we must be humble how we can do better. And last but not least, I would like to invite you all to EWMA Barcelona. Thank you for your attention.
Thank you, Kirsi. Thank you for this challenging ongoing case, clinical case, I would say. I don't know if we have specific questions about this last clinical case to you. Probably, Kirsi, you can sharing your screen, and we have no, and I can understand.
As there were some questions regarding your presentation, so there was, I think, one question about would muscle pump activator be used in case of ABI under 0.5?
Sorry,
What would muscle pump activator be used in case of ABI below 0.5?
I would say that it is on borderline. Can be used with caution, but in my point, it is not an absolute contraindication, but with surveillance, close surveillance, and with caution, I would say, with caution. And I think we have also one question for Katariina. If I'm not.
Yes.
If I'm not wrong, we have one for Katariina. Let me see where.
One question, did your patients keep the compression therapy both day and night after revascularization?
Yeah, I was just typing an answer. The lady kept day and night, but the gentleman only during the day. It was his choice.
Another point important to be discussed, Katariina, is about the use of this triple therapy after revascularization in elderly patients. So using aspirin, clopidogrel, and rivaroxaban. Can you explain in which cases you do not use this triple pharmacotherapy?
Yes, I think this is actually a rarity that we do use 3. Normally, because most of our patients are elderly and fragile, and so we usually go with the 2, either so that they go with if there's extensive endovascular treatment done, they go with aspirin and clopidogrel for 3 months or 6 months, and then change the clopidogrel into rivaroxaban. But this is according to the Voyager trial. actually the regimen should be these 3 medications, but many times the patient has to have good hemoglobin and no bleeding risks at all. So for fairly healthy patients, only this 3, that would be careful with that.
Yeah. Yeah, and I also have one question for Kirsi about this last question. And when have you clearly defined to go for an amputation of these 2 with osteomyelitis? In which cases, having osteomyelitis, do you decide to preserve the 2?
Well, I think a surgeon would be better to answer this question, but of course we did this together with the plastic surgeon that performed the skin grafting. But in this case, we realized that the second toe was very edematous. So it was like with some kind of a malformation and with the osteomyelitis. And as we agreed that it would not affect his walking so much to remove the second toe, so we decided it would be better to take that away. Would you like to add something, Katariina, or do you agree with me?
I agree.
Okay, thank you.
There was one question about the hyperhomocysteinemia. And interestingly, in this case, we measured the homocysteine levels and they were normal. I know from the literature that there are some reports about hyperhomocysteinemia, but I think it's a little bit fluffy. And we do measure sometimes homocysteine with this specific toe ulcers and with the metabolic disease profile. We have had like perhaps a very small percentage of hyperhomocysteinemic patients, and with this we of course supplement the B vitamin, but I would not consider it as a major etiology for these ulcers. Or what do you think, Joachim?
It's the same. We don't do that in regular practice, so only in special cases. So I'm not sure how many cases will we find if we test everybody, but when we test it, it is really in rare cases.
Yeah, thank you.
Well, if we don't have any more questions or comments, we are, I would say, at the end of our 90 minutes webinar. On behalf of ESVS, it was a great pleasure for me to co-share this webinar and having these outstanding speakers. And I would like to ask Kirsi to close the webinar and make the final remarks. Thank you again for this opportunity.
Thank you, Armando. Indeed, it was a pleasure. And we have had many thanks in the chat as well. And just a reminder that this webinar has been recorded and you will find it at the EWMA website and at the ESVS website as well. And please forward the link to your colleagues. And I'm sure that we will continue this fruitful collaboration in the future as well with ESVS, and we must fight together as one line for our patients that have really hard to heal ulcers, and this is the way we can improve our patient outcomes as well. Thank you all the speakers and all the participants for your active engagement, and we will see at EWMA Barcelona, right?
Thank you.
Thank
Thank
you.
you.
Bye-bye.
Thank you so much.
Bye-bye. Thank you. Thanks.